Good afternoon, and welcome back to Health Leaders The Winning Edge program, a weekly series of webinars touching on the topics and strategies that you need to know the most. My name is Chris Cheney, and I am the CMO editor for Health Leaders and will serve as your moderator for this session. Today's webinar is titled The Winning Edge for Building the Best Care Teams. Thank you to you and our audience for participating. Before we get started, for those of you participating in the live program, I have a few housekeeping details. Our program will be approximately 60 minutes in length. Note that an on-demand version of this program will be available on your YouTube channel on Friday and can be accessed through our website, healthleadersmedia.com. To ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you will find a resources list for today's webinar on the upper right of your screen. Here we have listed the webinar slide deck for you to download, along with a registration link for future The Winning Edge events. At the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our panelists. Joshua Bozek, CMO of Catholic Health's St. Catherine of Siena Hospital. Oren Cahlon, Senior Vice President and Deputy Chief Clinical Officer, NYU Langone Health. And Tipu Puri, Chief Medical Officer, University of Chicago Medical Center. Thank you all for joining us. Before we get into our discussion, I have a brief introductory comment. With workforce shortages impacting health systems and hospitals across the country, the effective formation and management of care teams is more important than ever. The physician shortage in many specialties is particularly challenging for care teams. Health systems and hospitals have risen to this challenge by employing more advanced practice providers to maintain care access and lighten the load on physicians. In recent conversations with health leaders, a pair of CMOs gave different takes on whether care teams should always be led by physicians or whether it is appropriate for care teams to be led by APPs or nurses in some circumstances. Jill Kalman, CMO of Northwell Health, says physician-led collaborative care teams deliver the best patient outcomes. Multidisciplinary care teams should be collaborative, with flexibility to adapt based on the patient's need and setting, Kalman says. Whether in the hospital or outpatient clinic, well-structured teams ensure the best outcomes. While the growing role of APPs help address physician shortages, physician-led teams provide the optimal structure for delivering high-quality, patient-centered care, according to Kalman. APPs such as nurse practitioners and physician assistants are going to play leading roles on care teams more often, according to Suzanne Wenderoth, Executive Vice President and CMO of Tower Health. Historically, CMOs and other healthcare leaders have thought that physicians should lead care teams under all circumstances, but that view is changing, Wenderoth says. Now, we recognize with both changes to the laws in the states, which allow for full practice authority for advanced practice providers, and the physician shortage in the post-COVID era, there has been an evolution in our thinking, Wenderoth says. Now let's get into our discussion. First, please tell me a little bit about yourselves and your organizations. And Tipu, why don't you go first?
Yeah, thanks, Chris. Pleasure to be here with everyone. I'm Tipu Puri. I'm a practicing nephrologist, and I'm the Chief Medical Officer at the University of Chicago Medical Center. This is the academic medical center and part of the UChicago health system. We serve the Chicagoland area and Northwest Indiana. We're about an 800-bed hospital here in Hyde Park, and have a very large percentage of Medicaid patients.
Joshua?
Thank you, Chris. I appreciate it very much. My name is Joshua Bozek, and I am the Chief Medical Officer of St. Catherine of Siena Hospital, which is part of Catholic Health, one of 6 hospitals in our system. I did a non-traditional route, first becoming a nurse before going to medical school, then going on to medical school. I ran several emergency departments across Long Island and into New Jersey for a period of time before taking on the role as Chief Medical Officer here at St. Catherine. And we are, like I said, a 6-bed system, but this hospital, we see up to 300 patients as we're a 296-bedded community-based hospital.
And Oren?
Great, thanks, Chris, and thanks for having me here. It's a pleasure to be here. I am a practicing radiation oncologist. I specialize in breast cancer. Been at NYU Langone Health for about 2.5 years, overseeing the faculty group practice, which employs about 5,000 physicians, as well as the clinically integrated network, which also has a voluntary physician practice of about 1,000 physicians, and about 350 ambulatory sites. We make sure that the operations at all of those sites are functioning well, both for our staff and for our patients. And our physicians practice at 6 inpatient locations across the region.
Excellent. So when it comes to collaborative care, how can you foster interdisciplinary teamwork on a care team? And Joshua, why don't you go first?
Sure. I find that fostering this interdisciplinary care team really works best when we are formulating our rounds in the morning. In particular, we do something called SNAP rounds. I'm sure several of the other hospitals are doing this, but bringing in all the different walks of life in the hospital makes a big difference, whether or not that's physical therapy, care management. Obviously, we need the nursing team there, the physicians, and several other departments such as pharmacy. This can help us with discharges. This can help us with making sure we have the appropriate care team individuals present so that we can give the best quality care.
Tipu or Oren, anything to add?
Yeah, thanks, Chris. I'll echo what Joshua mentioned. We're a teaching hospital, so in some ways this is ingrained in our culture. But I think in terms of fostering teamwork, it's really about everyone on the team feeling valued and feeling like they're making contributions that impact patient care. So having structures in place where everybody can provide input, where there's respectful communication, I think are really essential to creating this interdisciplinary teamwork and really supports the best interests of the patient.
And Chris, maybe I'll just add, I totally agree related to the inpatient side of things. We, in my role, I focus mostly on the ambulatory sites. And, I think interdisciplinary care is critical in the ambulatory setting as well. Certainly on the inpatient, I think a lot of hospitals have figured out on how to maximize safety, efficiency, multidisciplinary care. On the outpatient side, I think it's challenging. We have, I think historically multidisciplinary clinics have been used, but in certain specialties like cancer and perhaps a few others, highly specialized fields, we find that it's difficult to actually implement multidisciplinary clinics. But we have a lot of co-localization, big multi-specialty offices, maybe, 100 doctors practicing in many different specialties, and just having people co-localized, in the same office where they can stop by a colleague and say, hey, I have a patient. Hey, I have a question. Hey, can I curbside you for something? We have found to be very helpful. I think patients appreciate and can feel the connectivity when doctors and teams are, in the same building and they can tell there's good communication. I'll say we use a lot of technology as well. I think via all of our doctors and all of our sites are on the same EMR. And I think, these epic chats and secure chats that a lot of the EMRs have really foster interdisciplinary care. So even if you can't be together caring for the patient at the same time, you're constantly communicating. And, lastly, I think one thing that's a challenge is just documentation. To know what the other doctors are thinking and the other care members of the care team, reading their notes. Obviously, being on the same EMR is great, but if the notes aren't there and the notes aren't complete and the notes aren't signed out, sometimes that can pose challenges. So we really try to emphasize documentation and timely signing of notes.
Oren brings up a great point, and that I just saw a patient in clinic yesterday who I mentioned that I had spoken to some of her physicians about her care in between our visits. And it was really, I think, either surprising, which it shouldn't be, or just made her feel better that her various doctors and caregivers, members of the team, were communicating. So those structures that you all are putting in place to foster those informal conversations, I think the patients really appreciate it. Plus, it creates just a more collegial and collaborative work environment, which probably makes everyone feel a little better about their day at work.
Yeah, I wanted to piggyback off that as well, which, I don't think I mentioned. I'm an emergency medicine physician by training. And, I think that interdisciplinary care team, we oftentimes think of as an inpatient world or realm. And Oren, again, you brought up a good patient, a good point, which is that it's also in the outpatient realm. We use this in the emergency department frequently when we're trying to plan care for patients, whether or not that's, getting care management involved for transport back to a nursing facility, whether or not that's working with our local pharmacists to make sure patients are getting the right medications in a timely fashion, particularly if you're in a locale where patients maybe don't have access to certain things. So I agree, we have to look at this outside of just an inpatient realm and also look at it as an outpatient. Great point.
Excellent.
Chris,
go ahead.
I don't know if you're going to bring this up later, but this often leads then to the point of access, because a surgeon is seeing a patient and they before they can get the patient to the OR, they want to make sure they're optimized medically, and they need an endocrinology consult or some cardiac testing, and then having you mentioned the physician shortage. A lot of specialties are struggling. A lot of health systems, including our own, around having enough doctors to see the demand of patients. And so, for real interdisciplinary care to happen and be optimized, you have to be able to get patients in to see specialists and subspecialists. And, I think that's a challenge that we're all facing, and maybe we'll talk more about later.
Great. Building a culture of compassion. How can you effectively train and support a care team? And Oren, why don't you start us off?
I think it's around focusing and putting the patient in the center of it. If you focus around people's roles, then, oftentimes I think the conversation can veer into the wrong direction. But if you focus on what would I want as a patient, how do we want to be treated, how would we want our family to be treated, and then, I think everyone quickly aligns around the issues of, quality, access, timeliness, and all of those things. And so, everyone is overworked, everyone is, burned out. But again, if you focus on, that today this is a patient, tomorrow it can be one of us, our employees, or our family, I think people quickly, remember how important it is to be compassionate, kind, and thorough.
I completely agree with that. I think in general, everyone in the healthcare space can rally around the needs of a patient. but I think we also live in a world now where we're required to respect that people have lives outside of medicine and healthcare, and so there's a balance there that everybody needs to respect and understand that might look different for different people. And just because you have one way of looking at it doesn't mean that every member of the team is going to look at it the same way. But I think if we frame things in what the patient needs, and we start from that place, I think that's how you can train and support a team around that.
Right. I also wanted to mention, compassion, empathy, caring. These are all things that, if done well, can be quite infectious. You can see this throughout a building. When you have leaders that lead with compassion, you'll find that the rest of the team will kind of fall into line, per se. They oftentimes will feed off of that, and I've seen that time and time again. When you have different types of leaders, and that's not just by the way you treat patients, but it's by the way you treat all staff members. In addition, working in an environment like that, a caring environment, people want to come back. They want to provide the best care. They want to be part of that team, and they will just kind of exude that compassion and empathy. So I think it's so important that we do that.
And Joshua, just tell me a little bit more about how leaders can foster that kind of an environment.
Well, I think you lead by example. That's the first thing. I've always found that that's one thing that I've done well throughout my career, is try to lead with empathy, whether or not that's caring for a patient or caring for other staff members. People see that the way that you treat people. I've never once in my career raised my voice. I've worked in the healthcare facilities for 30 years now, and I've seen all types of different personalities come through. And you'll be surprised when you have a leader that comes through and does exude compassion and empathy, that everyone just kind of breathes a sigh of relief. And I can't tell you how many times I've come on shift and heard people say, "Oh, thank God it's you." And the reason they feel that way is because they know that you're going to be compassionate if it's a frustrating day. They know that you're going to understand that maybe they can't get to something as quickly as they want. Yes, we ultimately want our patients to get the best, quickest, most efficient care, but we also have to do that in a way that's safe for both patients and the staff members. And so when they see that you do that, then the next person kind of follows suit, and the next person follows suit, and we just see that domino effect.
Embedded in that is this idea that you also want to avoid being judgmental. I think people can make judgment. If I'm going to do something a certain way, I'm going to spend a certain amount of time, and if somebody does something differently or has a different amount of time they spend on it, there can be this tendency to judge or create this judgment of how much they care about the patient or how much they care about what they do. And I think that's a very risky environment to be in. And as leaders, we have to make sure that we're not putting value judgments on team members unfairly because they're making different work-life balance choices, or they're making, they're prioritizing a little differently. And that means they don't care about the patient. I think that sort of environment is the exact place where, and that's probably the environment that Josh creates, and that's why people love seeing him, leading the team when he's on a shift.
Yeah, agreed.
Anything else on this topic before we move on? Excellent. How can you optimize the role of advanced practice providers in the inpatient and outpatient settings? And Tipu, why don't you start us off?
So this is an evolving subject. I think it starts with, again, APPs wanting to feel valued for what they do and what they bring to a team. And sometimes that means creating structures and rules that allow them to practice at the top of their license. I think that they want to be challenged. They want to be independent. But at the same time, I think that it's fair to recognize that training is different, and there are, it's important to understand that. And I would want, our APPs to be challenging themselves and pushing themselves to learn more, but to also know their limits and know when they need to ask for help and know when they need to run something past a colleague or a collaborating physician. And so I think it's creating that environment or that culture where they can feel challenged, they can feel empowered, but they also have mechanisms to ask for help without someone questioning their ability.
Joshua, you want to chime in?
I do. So in these cases, one thing that I've learned to do over the years, and I've been running a practice with, as many as 15 to 20 APPs in an emergency department, is when we do the ongoing professional evaluations, I always bring it to them and I say, I want you to give me 3 goals. I want them to actually bring the goals to me and say, what is your goals? What do you want to do in this practice? Where do you see yourself, over the next 6 to 9 months? What do you think you can bring? And that's going exactly to what you're saying, which is, they want to practice at the top of their license. I don't think anybody really comes to work and says, I just want to skate through. They didn't go through all this training just to kind of skate through a shift. They want to bring and show you what they can do. And so I think by bringing out those goals, it really makes a big difference. The other thing that I do is I oftentimes will sit them down and say, what do you see as your roles and responsibilities in this in this role, and especially my lead PAs, I'll actually make that's an expectation I have of them, and that's to go through every year and update their roles and responsibilities to see, is there anything new that they want to add? And you'll be surprised where they start and where you see them 3, 4, 5 years later, they just keep adding and expanding, and it's amazing to watch them grow in that role. Now that's mostly had been in the outpatient setting in my career, as I did mostly emergency medicine. But now, as the chief medical officer, I've continued that while I work with my lead PAs, whether or not that's in neurosurgery, ortho spine, whether or not that's orthopedics, cath lab, etc. And they really enjoy doing that. And I think that's giving them an opportunity to be a big part of that, and that's how they're optimizing themselves.
Chris, maybe I'll just add a little more from our perspective on the outpatient. We have about 1,000 APPs in the hospital and then 1,000 APPs in the ambulatory network. Like in everything, there's huge variation of how APPs, I think, are used, are optimally used, can be used across specialties. Surgical specialties, I think, are different than medical specialties that are not procedural. Certain specialties see patients, almost weekly if they're getting active therapy, like, an MS patient getting infusions or a cancer patient getting chemotherapy. So I don't think there's one model. I think practicing at the top of your license, I agree people, there's this agreement that people want to do that, but, I think people also want to be supported. And, as Tipu said, they don't have the same level of expertise, and people want to make sure that they're challenged, but also not doing anything beyond their knowledge. And so I think, some people want to see patients independently. Some people want to do shared visits. And sometimes for a certain type of practice, seeing 40 visits together in a day is better for the patients and the team than each one doing 20 independently. And so we have found that there is no real recipe across all the locations and all the specialties. And like everything, it has to be somewhat individualized. I think in terms of, training and who we look to hire, like was mentioned earlier, a lot of things you can learn on the job, because at the end of the day, a lot of people's practice patterns vary from one practice to the other and from one institution to the other. But what you can't teach, we find, is, kindness, compassion, caring. Those are attributes that are often, either there or not. Luckily, most healthcare workers have them, but that's really what we look for when we're hiring. And the rest of it, the model and whether you do independent or whatever, we can teach that and figure that out.
And how do you address the issue that APPs don't have as much training as physicians? How do you address that issue on a care team so that you're not alienating the APPs?
Yeah, I mean, I could tell you, like in my own practice, let's say I do breast cancer radiation. The APP sees about 90% of my follow-ups completely independently. And it's because, in a very specialized field, most of the follow-up visits have, very finite number of issues that we're looking for that we address. And after, 6 to 12 months of working together in a shared way, they are ready to be independent. And, we offer people to see me, but the waits are longer and, things don't run quite as smoothly in my clinic. And so people, are very happy seeing the APP. They feel they get the absolute right care. And, I'm always around in case something comes up, but 90% of the time it doesn't. And I think it makes the patients feel good. Things run more smoothly, and it makes the APPs feel like, they are real independent providers.
I agree. I'll go back to, though, also something that Joshua pointed out is I think rather than being prescriptive and dictating what APPs should be doing, I think it's important to get their input. And again, Oren said this, that it varies by different settings and different practice models, but ultimately starting from a place of what do you feel comfortable doing, and that will change over time as they get more experience as well, right? So revisiting that conversation, but starting with what do you feel comfortable doing? How can I support you? What kind of, how do you want input or, if you need it? I would hope then, I would hope that most APPs would recognize the difference in training and experience. I think if they don't, then that's a problem right up front that, and it may be a separate discussion. But just because there is a difference doesn't mean that they don't have an important role in providing care to patients. But I think starting with their input and their goals is probably a good strategy to prevent them from feeling alienated.
Yeah, and the great point, Tipu. And on the job training and education, I think is really vital and key in this case. As we know, APPs can float between different specialties all the time. We as physicians, we oftentimes have done a residency and we've kind of concentrated our lives on one particular portion of medicine. So what I do is I just try to give them really good training and education, and then I've had on both sides. I've had sometimes patients, they see the PA and they think they are the physician, and they may even know that they are the PA, and they'll still call them Dr. So-and-so because they just gave them such great care. And then on the other side, I get sometimes where patients will say, oh, I don't want to see the PA. I want to see the doctor, thinking that, that they maybe don't have the skill set in order to care for them in the way that would be best. So oftentimes I will actually bring that PA with me, and we'll go and we'll do that as a team. And I'll kind of integrate them into the conversation to let the patient know how important they are in the role of taking care of the patient, and showing them and almost letting them showcase their knowledge within that area. And a lot of times that can kind of reduce a little bit of the stigma that physician assistants maybe aren't trained as well. I think we've all worked with some mid-levels that were amazing and some mid-levels that maybe needed additional training and education. But that, to me, the key is just providing that on-the-job training and education, and then what comes with that is they start getting the confidence needed in order to just take care of patients. And when you're doing a great job and giving excellent care, and you're exuding that confidence, I don't think patients really have a preference. In fact, some primary care offices, the patients prefer to see the PA because they feel as though they, are giving such amazing care, and I've seen that happen too. So, education and training.
Excellent. So this question gets back to my introductory comment, which is, should care teams be physician-led, or can advanced practice providers and nurses play leadership roles? And Joshua, why don't you start us off?
So I think this could go either way. So I understood both points that you made at the beginning of this. I think a lot of times we think that these need to be physician-led. I think that oftentimes it's almost an expectation in a lot of the hospitals and systems that they want these to be physician-led. As long as you have a really strong point person that's knowledgeable, highly educated, and trained, I think that they can lead most care teams. So it really depends upon their level of training, confidence, et cetera, in order to do that. Now, I'm a little bit jaded because I'm a nurse and a physician. And so at one point I was debating, do I become a nurse practitioner? I decided for me, the best option, I was still quite young, was to go back to medical school. So I feel as though I could have done it in either role. I think that it depends upon the person as well. We have seen that not all physicians are great physician leads. So some physicians prefer not to be leaders, and they would rather just be on the team. And that's great. We need people in all walks of life. We need people to be on the team, and we need team leaders. So for me, I think that both could do it as long as they're highly trained, educated, confident, and know the role that they need to complete.
Tipu, you want to chime in?
Yeah, I did read I don't know if it was a debate or just the different perspectives you referenced on this topic. I'll be honest, I'm not entirely sure I understand the point of the question, because my answer would be yes. I think they can be physician-led, and I think Joshua makes a great point that not all physicians are, great leaders. So, but can advanced practice providers and nurses play leadership roles? Absolutely. Of course they can. This goes back to our basic principles of quality in medicine, that it just needs to be the right care at the right time at the right place. And I think you assess the situation and you understand the individuals involved and what their skill sets are, and then I don't think we should be, again, prescriptive or firm about this, that it has to be this person with this credential. I mean, I think you want to put the best person in that role, depending on the needs of the team and the situation. So there's probably some third rail in Chicago. We have NL system with a third rail. So for those of you that don't quite get the reference, but it seems to be a bit of a third rail topic because of kind of the trend towards more APPs needed in healthcare to provide all of the healthcare needed in this country. But I think we have to get used to the idea that the right person to lead a team should be the right person that leads the team.
Right. I wanted to just rebut on that a little bit. So when it comes to the care team in particular, I think it depends upon the care team. I think a lot of times we think of the care team as, the internal medicine team doing rounds on the floor per se. But the reason I say that is I have multiple different care teams that are led by PAs that do a phenomenal job. In particular, I'm going to use my neurospine team as an example. So this is a neurospine team. Every single PA on that team, and we have 8 people on that team, have 20 years or more of experience in the neurospine realm. And they do an unbelievable job of leading care rounds. The neurosurgeons in particular, the spine surgeons, are oftentimes, they just come in and they'll see the patient, have a little conversation. They're looking. Everything has been completed from them, from whether or not it's providing and getting them DME, making sure they have the right medications, speaking with all the appropriate people, making sure they have follow-up, et cetera. So they really are leading that team. If I was to take one of those neurosurgeons or spine surgeons, I mean, they're surgeons, right? They want to be in the OR, and I completely understand. And they don't necessarily want to be that physician lead in that case. But that's an example of a care team that's best led by a mid-level. And I'm sure there's a lot of other examples. Oren, I don't know if you have examples from the outpatient realm in radiology, but that's why I kind of was leading down that road as well.
Yeah, I totally agree. I guess the one area where we have found that it's helpful to have leaders across the disciplines is that, physicians often respond best to physicians when it comes time for, constructive feedback, what they could be doing better. And same with nurses and APPs. The nurses will say, oh, the doctors don't understand my role. The APPs will say the same. So I think, having leadership, at some point, obviously it has to converge, but, also as you go down, across nursing, APP, administrative, and physician, because, there is this sort of, I find it's harder for people to take feedback, especially when it's not as positive, from someone outside of their immediate discipline.
I'll add, both of my fellow panelists touched on this. Probably the bigger challenge for us in medicine is how do we make sure the patients understand the different roles? And as somebody, mentioned, they often refer to the APP as Dr. So-and-so. I'll get patients referred to me for a nephrology consult, and, a lot of primary care is being delivered by APPs, and they'll think my my doctor referred me. And on some level, there's nothing wrong with that. There's just some history in how that label is assigned. But I do think as these roles grow, we are going to have to figure out how to explain to patients the differences. And those differences don't mean you're getting worse care or inferior care, but it is important that you understand the differences. But correcting a patient in front of the APP to say, they're not a doctor, you shouldn't call them doctor, that's not appropriate either. So we've got to figure out how to explain this better to patients or make it more obvious to patients so they know who is providing their care.
Yeah, just an example of that is, a lot of times in my field, which is radiation, people will say, do you deliver the radiation? And I'll say, we don't actually deliver the radiation. We prescribe it, we design it, and we decide how much and when. But, there's very skilled technicians. And so, I'll often say, you will see a technician that's highly skilled. And, I'm happy to be there, but I don't even know how to turn the machine on. So I think it's really important that, people have respect for the people in the different, of the care team, because, I can't do what they do, and they can't necessarily do what I do. And together, we deliver great care. But I think, it's like Tipu was saying, we have to explain to the patients, not that I don't want to be at the machine. I don't know what to do with the machine. They spent 2 years training on how to work these machines.
And Oren, you made an interesting point about it can be challenging for negative feedback from care team members, outside of physician or nurse or APP. How do you cut through that?
Yeah, I mean, an example is, let's say, on productivity for physicians, having non-physician administrative leadership tell doctors that, they need to see more patients, or they're spending too much time with patients, and, you don't have an hour for a follow-up. You got to get this done in 20 minutes. That's a difficult message for doctors to hear from non-doctors. And so we use our physician leadership to do that. And to the point that was made earlier, leading by example. Most of our physician leaders, our chairs, our CMO, we're seeing patients as well. And so we're struggling with the inbox messages and, the documentation. And but we try to explain that that can't get in the way of seeing patients and access and all these things. And I think, you know, it's never that well received, but it's better received coming from someone who is doing it. And, you know, the same can be said for nursing APPs and throughout.
Good. Anything else on this topic before we move on? Okay, let's move on. How can you offload non-patient care tasks from a care team? And Oren, why don't you start us off?
Sure. You know, I think this is one of the big challenges in healthcare is that, you know, between, you know, pre-authorizations and documentation and coordination of care, you know, there's a lot of what people will say scut work or non-medical care that is involved. I mean, depending on what you read, for every hour you spend with a patient, there's an hour or 2 hours of, you know, additional work that needs to be done. And so we're using a variety. I mean, we still struggle with this, but we're using a variety of different mechanisms. You know, for example, for the documentation, we use scribes. There's also now AI-driven scribes, and that's this ambient, you know, the technology to just have a conversation with a patient, and then you get back to your computer, and there's a note generated. You know, I think that's still a work in progress. There's multiple people trying to address that. That would be huge. We have a pilot of 100 doctors currently testing 2 different vendors, in addition to the physical scribes. You know, inbox messages. We have a technology we developed for AI responses. So, you know, there's a message. First of all, we get rid of, we use AI to automatically unclog people's inboxes. About 15% of messages are thank you, oh, see you soon. And while those are very nice, you know, they end up clogging people's inboxes and distracting from the more critical ones for care. So we eliminate those via technology. And then we actually have completely written AI responses to people's messages. They're currently still reviewed, edited, and signed by the provider. But, you know, I think the time will come when many of these messages can be automatically responded to. You know, we have a group of APPs and RNs at a call center, some on, you know, in the area, some out of state and even out of the country, to help address questions, do pre-authorizations, and a lot of this other work. Because, you know, as you said, finding enough, you know, staff to take on this huge administrative and documentation burden locally has been very challenging. So we have offices in Florida, Las Vegas, Bogota, Colombia, Philippines, to recruit staff and support our needs that are non-patient facing, ultimately to let the providers spend as much time as they can with the patients providing direct care.
And those are APPs and nurses that are doing that from a centralized location?
Yeah.
Yeah, I agree. We've had some good success with some of the ambient documentation technology, but just taking a step back, I think, and there have been examples, again, from both the inpatient and ambulatory setting. But you know, it starts with asking. Sometimes teams will elevate. Our residents are often very vocal about things that they don't think, you know, residents should be doing. And most of the time they're right, whether it's, you know, making phone calls to get medical records for patients that have come in or making appointments. But it starts by asking or finding out what are the things that are taking time away from the bedside or time away from what you consider to be direct patient care. And then, you know, and then trying to figure out how you can support that. We've done it with putting, you know, embedding patient navigation coordinators with our inpatient teams that, you know, have the responsibility of attending multidisciplinary rounds and helping to make follow-up appointments and helping to make sure discharge summaries get sent to primary care physicians for transitional care management appointments. So for us, it started, you know, it starts with asking the teams. You're not always aware of everything they're doing, and sometimes as leaders, you need to just sort of embed yourself with the team and understand firsthand what does their day look like, and what are the things that they are doing that that they feel like, you know, perhaps they didn't go to medical school or didn't go to APP school to do these things, and could we find, you know, another member of the team or create a position to support that.
It's a very brief response, which is just really good delegation. But those that you delegate to, just make sure that they feel supported and thanked for what they do. Because without those non-patient care tasks being done, then we can't care for the patients. You know, it could be something as I had a conversation with the finance person recently who said, you know, I said, well, thank you for what you do. And he said, what are you thanking me for? All I do is just make sure that the bills get paid. And I'm like, if the bills don't get paid, we don't have supplies. We won't have a hospital to open. So your job is extremely important, and I thank you for that. And he almost had like a little bit of a smile where he's like, oh, I guess I really am participating in care per se. It may not be direct patient care, but everything we do is regarding patient care. So I think that's the way that I try to, you know, lead through my hospital.
Anything else on this topic before we move on? Let's get to one more question, and then we'll see if we can get into Q&A. How can you leverage technology to enhance care team efficiency? And Tipu, why don't you go first?
Here again, I think it's sort of assessing, having an infrastructure, which is something that we're developing right now. Is you know, left and right, you see new AI products coming out in the market. If you go to any conference now and you walk through the exhibitor hall, you're going to see all sorts of AI enhance this and AI enhance that. And so I think it starts with having, I think, an infrastructure at your institution or in your health system that that can evaluate. Some of it sometimes comes down to a build versus buy decision. But it's understanding the needs of your care teams and understanding the needs of the organization, and then seeing, you know, if you can find technology that will fit that need. I think it's important to make sure that good isn't the enemy of perfect here. You're never going to find something that's perfect. There's a lot of effort to find something that's perfect. And then the other challenge is the space is evolving so fast that there's always the next shiny new toy that comes out. And obviously, you can't be implementing something new every year. Just the process of it, getting it integrated into your, you know, EHR can take time, and you can't do that over and over and over again. So it's very challenging, but we've got to do it, because there's some great technology being developed out there that can really make, I think, healthcare more efficient and make our lives as care providers better, and provide better service to the patient. So we've got to do it, but it is challenging to find the right fits.
And Oren, you already kind of touched on the AI-driven email. I need to get that. I still get bogged down with the thank yous and you know, appreciate that emails, and that ends up being, you know, 250 emails a day when 150 of them could be AI, you know, scrubbed. You know, for me,
Josh, just on that point is, you know, it's still the feedback we're given on these AI responses is it's much nicer. They're much more polite and almost a little too, you know, too many words there compared to the physicians, that it's not quite believable. So we're trying to teach them how to be a little more to the point.
Yeah, like when I respond with TY, thank you, that's it, you know. So
exactly.
I can tell you from my standpoint, from either whether or not it's working in the emergency department or whether or not it's working in observation or inpatient medicine, it's going to be a really clean, high-functioning electronic medical record. At the risk of telling you which EMR we have, I don't know if that matters, but I've used 5 or 6 different EMRs over the last 15 years, and I can tell you that having a really efficient EMR and utilizing everything that you can do with it really makes a big difference. Whether or not it's generating reports, whether or not it's getting certain things out of the computer in a timely fashion, a quick fashion, easy to find documentation, easy to find media tabs, things like this, really enhances that care team, because we can get the information quickly versus I've worked with some EMRs where it take you 30 minutes to find a notation that you were looking for. Another one you go to, you can literally 2 clicks down, you can find it just in a search tab. So leveraging the EMR, I think, is really, really important. And now, of course, AI is going to be implemented in all of these EMRs to improve our functionality, so we can spend a lot less time with the computer and more time at the patient's bedside, which is ultimately what patients families want. They want to be, seen by the physicians, the clinicians, the nurses, but, we spend 50% of our time, what I sometimes describe as the cash register. Like, if we don't get all the data in, we're not going to get paid, et cetera. But really, I want to be at the bedsides, caring with patients, speaking with patients, going over, information, education, discharge instructions, et cetera. So for me, it's going to be EMR.
And Chris, I'll just add, given the financial challenges in healthcare that, many systems or all systems are facing, I think this is critical, and it does require some upfront investment. But, just for example, we now do 12 million ambulatory visits as a health system per year, and 3 million of them last year were scheduled online. So there was no phone call made, patients self-scheduled and got a visit. And, every call, if you think, how many calls can a person schedule, costs a few dollars. And if you save 3 million of those, it's not only more convenient. I know, like, for a reservation for a restaurant, if I have to call the place, I'm not going there. It's all online now. And so, I think the same is becoming in healthcare. People want to be able to change without calling someone, and it saves a lot of money. So I think, there's many examples that, we're pursuing, and I know other systems are pursuing, and will be important from a financial and patient satisfaction standpoint.
So we've got about 7 minutes left. So why don't we move on to see if we got any Q&A from the audience. First of all, I want to thank all of you for an excellent discussion. This now brings us to the Q&A portion of the program. So we now like to invite you in the audience to ask live questions of our panelists. As a reminder, if you are participating in the live program, to submit a question, click on the Q&A widget at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewed by other audience members. First question actually comes from me. I'm just wondering, if you had to come up with 1 or 2 key takeaways from this discussion, what would those be? And Joshua, why don't you start us off?
So the takeaways for this is that, in order to support the hospital, the workforce, et cetera, we need to lead by example. We need to be empathetic and compassionate. But in addition to that, we need to support the teams in a way that lets them know that we're there for them, that we are going to provide them with the support that they need, whether or not that's going to be technology, supplies, sometimes just the education, or sometimes just to be there when they have questions. And people come to I have an open door policy, most of the day. And people feel like they can come to me and they are supported. And lastly, it's just breaking down the barriers that they have in order to do their job really well. By doing that, they're going to be successful.
Tipu?
Yeah, I guess I would add. I think many solutions and many kind of defining roles and can come and should come from the teams themselves. I think many of these processes need to be more of a negotiation and an understanding rather than a top-down kind of decree of this is how we're going to do something. I think if we don't take the time to understand workflows and understand the challenges our care teams are facing and their own goals, then we are less likely going to hit the mark when we try to provide support that is, that's actually going to solve a problem.
And Oren?
I echo what my panelists said. I think it's it's interesting that whether you're in an academic center or a community health system, whether you're in New York or Chicago, the challenges and opportunities we're all facing are very similar. I think the potential solutions you hear a lot of commonalities amongst the three of us. And, I think while there's a lot of challenges, luckily, the people who have gone into healthcare are focused around the patients, delivering kind, compassionate, high quality care. And in the end, we'll find a way to do that.
And just one quick question, and I'll take a volunteer to answer it. What are some of the best practices when it comes to recruiting and retention for care teams? And I'd like to hear from one of you on that because we don't have that much time left. Any volunteer? I'll just ask somebody.
I have a landscaper right out of my window. I don't want too much background noise.
Sure. Are you talking about recruitment and retention of physicians or all staff?
For all staff, because these care teams are multidisciplinary, and we're all facing workforce shortages across healthcare right now. Yeah. So, what are some of the best practices when it comes to recruitment and retention?
Yeah, it has been a challenge. I think it's around listening to our employees and giving them an environment that gives them flexibility. A lot of people want autonomy. And like Tipu said earlier, some people want to work full-time. Some people want to work more than full-time. Some people want to work part-time. I think flexibility benefits a positive culture where the leadership may be dealing with a lot of challenges, but that doesn't get conveyed down to the staff. To the staff, it's focused around the patient, and they don't need to know, that there's budget shortages and reimbursement challenges and all of this. And it's at the ground level. I think it's important that people realize that the organization is committed to giving the best care. And the leadership can deal with the issues.
Excellent. We're down to the last couple of minutes, so I think we're going to wrap up. In closing, please note that our next program on March 18 will cover the winning edge for battling Medicare Advantage. A live clickable link will appear at the close of this program, taking you to our registration page for the event. Remember to follow along all week as we cover strategies for building the best care team on our website, healthleadersmedia.com. I want to thank our panelists once again for an excellent discussion. Finally, thank you to you and our audience for participating. We hope you enjoyed today's program and look forward to seeing you during our next program on battling Medicare Advantage.